I mean, how would you even begin to parse what matters on a patient when they come in with something like heel pain?
So the easiest way to go about it, it is a bit trickier when you have bilateral symptoms, but if it's unilateral, it's easy because it's like, which one of these is not like the other? And if you find something that's restricted on the symptomatic side and not restricted on the asymptomatic side, it's like, okay, we can put that in our bucket of relevant things to make more like the side that doesn't hurt. So with unilateral problems, it's a lot easier. And I treat every foot like it's a hip, because the old Angry Charlie quote, Charlie Weingroff, he said that he's never met a foot that a hip can't fix. And you don't always have to make it a hip, but I always keep it in the back of my mind so I don't get so distracted like a toddler with jingling keys on the local restrictions, because there's a lot of things locally in the foot and ankle that everybody sucks at. And if you don't like expand your net out to at least encompass up to the hip and lower back, your results are going to be temporary at best. So to if it is bilateral, it is a little bit trickier, and you have to do a little bit more examination of the hips and the lower back, and take a little bit more of like a systems history of, all right, are you diabetic? Do you have thyroid disorders? Any past ankle sprains, things like that. And I know that everybody calls an ankle sprain something different, because I'm sure, John, growing up playing soccer and with your athletic background, you've rolled ankles and they've swollen up for a couple days, and there was probably some ligamentous damage, but we wouldn't qualify that as a sprain. So you have to really kind of reframe the way you ask your questions.
Yeah, I mean, I hear you say it's easy if it's unilateral, and I'm imagining a few people out there going, okay, even the Henrik Reels out there, the people that research these type of things, going, okay, I'm not so sure it's always so easy. But I mean, I believe what you're saying, but are you kind of insinuating that we start with whatever would be maybe the easiest or most logical answer first, and if that doesn't solve it, and you go further? Because even though it's unilateral, there's still spirals and connections to the opposite side of the body, and top down versus bottom up process, problems. Does that make any sense?
Yeah, and I try to take an Occam's razor approach to this. And I just listened to the podcast with that guy on it yesterday. He was on the Physio Edge podcast, and it sounds like he's publishing a lot of new research, new study out on cortisone injections in conjunction with loading. And he's pretty laid back on how he prescribes rehab, because he's like, I'm going to give people the rehab exercise that they'll do, even if I think there's a more effective one. If I don't think they're going to do it, it doesn't work very well sitting on the shelf just looking pretty. So he is just like, yeah, I don't make it hard. Like, if the insert's more comfortable, I have them wear that one, despite what the nitpicky literature says. And if I have to spiral around to a contralateral hip, or explain like the dynamics and biomechanics behind their problem, and I'm trying to make it complicated to entertain myself, I'm going to waste half of my visit trying to explain to a patient why this is connected. And if you start, you do a global assessment, but then you kind of zoom in locally if there's stuff to shore up there, because people have more buy-in if they're doing stuff in the area that hurts.